Welcome to another installment of the Lympho vascular terrain series. This is part 3, cranial and cervical lymphovascular terrain. My name is Ivan Dubin, and I'm an osteopathic practitioner located in Vancouver, Canada. The following presentation is not intended to replace the advice of a physician or a medical specialist. For medical advice, please consult your doctor or a medical professional regarding any potential diagnosis or disease management concerns you may have. This material is intended for health practitioners who are interested in viewing information on the role and complexity of the lymphovascular terrain. In terms of the overview, we're going to review some of the anatomy contributing to the body's lymphovascular terrain, review of typical lymphokinesis physiology, introduction to the glymphatic network, talk about pressure gradients and intracranial pressure, discuss the selfish brain concept, otherwise known as Cushing mechanism hypotheses, talk about inflammation and degenerative disorders affecting the cranium. Then we'll get into cervical and cranial lymphovascular terrain specifically, examine the deeper cervical lymphovascular terrain connections below the diaphragm as well to bring us back to the rest of the body. Then I'll finish up with talking about forces behind cranial bone motion, including the PRM, primary respiratory mechanism, NCSF, cerebral spinal fluid, and in relation to blood flow, and some interesting notions around what's actually driving the motions that we feel under our hands as practitioners. Just a quick review of lymphovascular terrain. Includes all connective tissues and all fluids that contribute to the living human being, otherwise known as the living bioplasm. The terrain is the result of interrelationships of the lymphatics, all connective tissues, including the nervous system, and all vascular structures coexisting in one ecosystem or medium. Ultimately, the terrain of the body is contained within a pressurized living metabolic sponge of varying tissue tensegrities, tissue densities, electromagnetic properties, and also chemical gradients. This image does not include the nervous system, but it does exemplify the essence of the lymphovascular terrain. Also, there's no reference to connective tissues in general, although they talk about tissue cells. So we can see this interaction. In the green, we have the lymphovascular, obviously arteries in red, veins in blue, then the small tissue cells, and in between the spaces we have interstitial tissue fluids. And I think what's valuable here is to consider that the entire mechanism creates a type of a weave as everything sort of blends in together. And it's almost as if the lymphatic system is sort of growing in between all these tissues, and the other tissues are sort of organizing around it so that it allows for this sponge-like quality. Let's move on to another image. This image shows the subdermal layers, including the interstitial tissues, but we can project this image to deeper layers of the body by replacing the dermal layers with organs and connective tissues. Later, when I review the pressure gradient dynamics in tissues, I'll be referencing this image as an example of the environment that participates in this phenomena. This involves a transition of proteins leaving the arterial system by osmosis and diffusion into the interstitial spaces to be picked up by lymphatic structures in the venous system. So here again, the green being the lymphatics, and here around surrounding the lymphatics and in between the arteries and veins, we have an interstitial matrix, which is the interstitium is now considered an organ. So these structures are nestled within this organ, and within this dynamic of the organ, we get the exchange of osmosis and diffusion, whereby toxins are leaving the arterial system, going into the tissues, and then being absorbed by both the lymphatics and aspects of the venous system as well. Another image, subdermal. This image makes it easy to understand why the skin is often referred to as the largest organ of detoxification. And you can see how interwoven the structures are under the skin. And once again, of course, we don't have any nerve fibers included in this particular image. Also note how the structures get smaller the closer to the surface of the skin, and the further you go into the body and the tissues, the structures get deeper. Talking about deeper, moving from the superficial lymphatics to deeper lymphatics, the next couple of images will give us an indication of that. And note that constantly, even at the deeper levels, we have the association of the lymphatic vessels with the neighboring arteries and veins. And here we've got organization around muscle and bone. This is likely the thigh or femur. And also within the layers, if I'm just looking between connective tissue layers, there's also this matrix of lymphatics occurring as well. And then even when we get to this deeper area where we have the primary artery and vein, we can see that the lymphatics are following along and are associated as well. And then inside the muscle belly, we can see also how the lymphatics sort of branch out. So they are on almost every layer. And there are also lymphatics going into the bone, which I'll show you next. Before going to the bone, just to show some of the lymphatic vessels supporting the spinal nerve roots as they exit from the spinal cord. So obviously here we have a segment of the spine, and we can see the spinal cord, the relative layers of dura, and this is an example of a nerve leaving, spinal nerve leaving through the vertebra, and how it's associated with lymphatics. So we've got the yellow nerve and then the green lymphatics. So again, even the nerves are supported by some element of lymphatics. This image is taken from a study that reveals an actual increase in lymphatic vessel perforations in bone following injuries. So we could consider these lymphatic vessels to be part of a deeper lymphovascular terrain. And so here we have the femur, I'm assuming, before injury, and then here after injury. And it's showing through imaging that there's a perforation of lymphatic vessels that are recruited in order to facilitate a healing process, or at least they're more active. So there's an increase in activity in the lymphatic system. So moving back to the superficial lymphatics, this image represents more of the territorial lymphatic chains as well as superficial lymph nodes. Note the multiple directions of lymph flow, or otherwise known as lymphokinesis, available for most nodes. And most nodes generally connect to 2 or 3 other nodes. There are some solitary nodes in the body that are at the end of a line, but most of the time we have this interconnection. And so this is just superficial. However, it's one dimension, and as I'll show, or I have shown in previous presentations, there are deeper layers. These lymph nodes connect deeper to the body and go and correspond to various organs and such. Just appreciating what goes on with the lymph node, this image reveals how each individual lymph node has both arterial and venous supply, supporting its role in detoxification and immunity. You can see that in this image with the red and the blue. Each lymph node is a filtering station where lymph interacts with blood flow before moving on to the next lobe in the chain. This is an indication that lymph is interacting with the vascular system throughout the body rather than just flowing through the lymphatic system and reaching its goal of the venous angles back into blood flow. We can see that these lymph nodes are getting support and are connected to blood flow in the vascular system everywhere in the body. And so they're participating in that detoxification process and sending information immediately, sending and receiving information from the blood flow immediately. Another example of a lymphovascular terrain here, we have the microvilli, the intestine. We can appreciate the lymphovascular terrain encompassing nerves and tissues as well as mucosa and interacting with the microbiome. Note the microvilli and keep in mind how small these structures actually are. So yes, coming here, we definitely, let me use a color here. Let's try this one. So we have the microvilli, individual microvilli. Within them, we have your arteries, your veins, your lymphatics. And also there you can just fairly see the yellow, the nervous system interacting as well. And then we have these orifices, the crypts of Labracoon, which is also a popular place for bacteria, beneficial or unbeneficial to position themselves. And then there's also an interaction with a mucosal layer that is where the microvilli are interacting with, and that also encompasses a microbiome, allowing for the absorption capacity to be facilitated for the microvilli. They do require a healthy bacteria to properly absorb. And then, of course, as the absorption occurs, there's blood coming in and blood leaving each microvilli. So nutrients are entering back into the bloodstream, and some are continuing on in the small intestine to be absorbed further down, like in the colon. But nevertheless, there's a huge lymphatic component just in the small intestine, and dozens and dozens of lymph nodes located in the small intestine, and just the digestive system itself is about 40% of all lymph nodes are supporting the digestive process. Additional components of terrain, we have the mucosal associated lymphoid tissue, otherwise known as MALT. This includes the entire ear, nose, throat, ENT passageways, the respiratory tract, digestive tract, and reproductive tract. All of those have mucosal associated lymphoid tissue in them. The name changes depending on where it's located in the body. All endothelial and epithelial line structures have one or more mucosal layer forming or contributing to an immune barrier. The microbiome and bacterial environment is embedded in various mucosal layers and is proving to be a critical factor in the dynamics of health within the terrain. You can learn much more about that in my part 2 presentation. Optimal terrain function also exhibits the aspects of the structured water phenomena. However, I'm not going into great detail in my presentations on that. There are other sources out there that will talk about the structured water phenomena within the body. Since we're going to be focusing on the cranium and cervical, we do want to consider the mucosal aspects of those areas. The ENT and the digestive system and the whole area is just capable of producing mucus in its various different areas. It contains mucin, and this is a major barrier to infection. The mucosal layer serves as a type of barrier between the outside world and the host. It's composed of rapidly replicating arrays of epithelial cells, The sensing of the external environment can occur via the extensive nervous innervations, since the cells are actually avascular in nature. And the mucosa provides microbial, biochemical, mechanical, and anatomical barriers to prevent infections. Recent studies, the mucus layer not only acts as an important factor for protecting the host against microbial invaders, but also contributes to the mutualism between the host and the microbes. Many diseases are associated with the alteration of the mucus layer thickness, but it is still difficult to identify whether this effect is a cause or a consequence of the disease. Additionally, recent evidence suggests that specific gut microbes contribute to the regulation of the mucus barrier and eventually intestinal and host health. It's going to move away from the anatomy a little bit because we're going to revisit it when I get specific to the cranial and cervical lymphovascular anatomy, and we'll follow it down through the body, and I'll show more of the deeper connections of the lymph nodes. This was really just to give you a sense of the texture of it, and that's capable of being at multiple layers. So let's just go a little bit into the movement of lymph or lymphokinesis. According to Foldy, the lymphatic system runs parallel to the arterial and venous system. The characteristics of the lymphatic system are as follows. It begins in the periphery with initial lymph vessels. Along the way, the path of the collectors are interrupted by intervening lymph nodes. The flow of collector trunks goes into the venous system. The terminal site is a confluence situated at the left and right venous angles. The lymphatic system can be seen as the integrator of all bodily fluids and as the second circulatory system. And if the lymphatic system would cease to function, the result would be a massive edema, retention of toxic metabolic wastes, and death within 24 hours of onset. Now, I want to point out that these are classic views on how the lymphatic system is working in terms of where the volume of lymph is going and where it's entering the blood flow. And so, as I've already pointed out, there are other areas in the body where the lymph is entering the blood flow. It doesn't just wait to get to the venous angles. It's happening on all levels of tissues, especially where you have lymph nodes, and including in the cranium, because inside the cranium, as I'll point out, there are no lymph nodes inside the cranium. The glymphatic system is a different thing altogether. So, continuing with lymphokinesis or lymph flow, the majority flow of lymph moves back towards the heart via the venous angles under ideal or optimal pressure gradient dynamics. The flow of lymph must travel against any deep and superficial tissue resistance that surrounds the arteries, veins, and nerves. There is no central pump of the lymphatics. Rather, the flow relies on our ability to move our body and on ideal tissue pressure gradients when we're moving less or not moving at all. Exceptions to lymphatic flow occur around the liver, as it acts more like a lymphatic hub, moving lymph in multiple directions, meaning superficial to deep, and back again, and cranially or caudally in the body, depending on the needs of the body and the individual. This is also the case with the flow of lymph inside the mediastinal area, which moves lymph away from and towards the venous angles, moving from deep to superficial and superficial to deep lymph nodes. So again, I'll touch upon it a little bit as we move through, but we do have this movement of lymph occurring to deeper layers, and from deeper layers to superficial layers, depending on the situation for that region of the body. Okay, so we're just going to introduce a couple of slides with anatomy just to continue talking about lymphokinesis and just the lymphatics in general. Before that, we'll continue on. Perhaps the best way to appreciate the anatomy and function of the lymphatics is to overlay it on top of the vascular system, which I call the vascular tree. This allows a three-dimensional context to appreciate what is under the hands of a therapist. Also allows for the appreciation of how the lymphatics have a deep and superficial layer connection. The vascular tree is supported by a pressure gradient and chemical gradient dynamic. The human body is a living matrix of biological and physiological forces working to maintain homeostasis. The mechanics of homeostasis rely upon ideal tissue and vascular pressure gradients as they interface with oxygenation to nourish the blood. There are tensegrity dynamics between various connective tissues and organs. They create the structure governs function paradigm that's also embodied in pressure gradient imbalances. So we can certainly have mechanical disadvantages presenting around within the connective tissue matrix that is influencing blood flow, which will change pressure gradients and will influence lymphatic flow. It's important to note that the concept of measuring blood pressure in the body is not necessarily to provide information regarding any specifics to heart function or blood flow specifically to the left arm, but it does provide you with information on how hard the body is working to deliver blood to the entire body. So the more tissue resistance, the more pressure gradient issues surrounding connective tissue around organs or specifically within organs affecting blood flow, this changes the dynamic. It creates a tone or a density or a pressurized system that affects blood flow and creates this stasis effect. Now, that can happen in the mediastinum, and that would certainly have an impact on cranial and cervical lymphatics. So that's something that we will revisit as I'm moving on. Continuing on with a quick review. So obviously when we look at the human body, we can see the vascular system and venous system in this image. We can clearly see that it extends up into the cranium and cervical spine. The head and neck is connected to the rest of the body. Seems self-explanatory or self-evident, but it's important when we're isolating to keep in mind that there is a bigger connection. I'm going to put the diaphragm in just for reference. And in terms of the lymphatic system, we know that in terms of lymphovascular terrain in general, the blood flow goes from the center to the periphery via the arterial system, and then comes back from the periphery to the center with the venous system. The lymphatic system accompanies the veins and the arteries almost like a vine trailing a branch. And it will do so anywhere there's an artery or a vein. It will have an accompanying lymphatic structure with lymph nodes as well. We also have the thoracic duct, which starts below the xiphoid process next to the aorta. That thoracic duct comes up and branches off into the left and the right side. We also know that today we're going to talk about the lymphatics coming down from the head and neck, interacting with the lymphatics of the mediastinum. I'm not going to go through the whole body here, but what's important is that this entire system is relies on ideal pressure gradients. In particular, that diaphragm will have profound impact, since above the diaphragm we have negative pressure gradients, and below it's positive pressure gradients, which means that the body has some help in moving blood out to the periphery, and then there is the negative pressure around the lungs and heart allows for some type of a suctioning back to the venous system, back towards the center, to the heart. So if there's resistance in any tissues or areas of arteries or veins, it can affect the lymphatic flow. So important, because we're going to be focusing on the head and neck, but that the symptoms that you may have there are not always, or the structural deviation that you may find posturally or through palpation or mobilization may not be a local cause. It could be the body responding to something going on down below. Another important distinction of the lymphatic system, other than it accompanies the venous and arterial system throughout the body, is that it's divided into two sections. So the right side of the cranium, the right arm, portions of the right side of the diaphragm, liver, and right lung are drained into the left venous angle, and the rest of the body, which includes the right leg, left arm, all the way up to the left side of the body, left lung, left portion of the diaphragm, and then the majority of the lower extremity from here, more or less. There is some change of activity around the liver. As I talk about, the liver is also a hub for the lymphatic system. So there is this division, and I suspect the division is there to provide backup to protect the brain on some way, so that if one side is infected, the other side might be able to sustain some function or distance itself from what's going on. But there's really no explanation as to why the body is divided in this way in terms of lymphatic flow. So in general, what we need for optimal lymph flow, or what's called lymphokinesis, we need ideal pressure gradients surrounding the arteries. Excessive pressure around the venous angles will limit lymph flow in the area. Excessive pressure in the mediastinum will limit lymph flow, and that's in both directions, superficial to deep and deep to superficial, as well as mostly going cranially, heading up towards the venous angles. Excessive upper cervical or pleural dome tension will limit lymph flow. Excessive tone in the diaphragm will limit lymph flow at the entrance to the thoracic duct. Also, suboptimal liver function will limit lymph flow. And suboptimal intestinal function will limit lymph flow. Also, we have scars from surgeries, which can limit lymph flow. And obviously, if you have lymph nodes removed, that's going to have a negative effect on the area for lymphatic flow and cause the body to compromise and try and pick a different route if one is available. Looking at the glymphatic network, we're including the glymphatic system, the meningeal lymphatic vessels, superficial cranial lymphatic vessels, including the scalp, face, and jaw, the venous sinuses. Cerebral spinal fluid movement also contributes to cranial detoxification, so that could be considered part of the glymphatic network. And we have deep and superficial lymph nodes of the cervical spine, upper cervical, And we have the mucosal layers and Waldeyer's ring, which is inside the throat, which I'll be covering. So all these things are going to be covered coming up. Looking at the glymphatic system first, there's a pathway for cerebral spinal fluid to enter the brain parenchyma via the periarterial route called the glymphatic system. The system is responsible for clearing the interstitial compartments of the brain and spinal cord by acting as a clearing mechanism for the removal of extracellular solutes and interstitial fluids. It is likely that arterial pulsations, as well as the expansion and contraction of the brain extracellular spaces, are responsible for the change of solutes between the interstitial fluid and the cerebral spinal fluid. So we have a filtration process that's going on as part of the glymphatic system. And I think it's worth noting that arterial expansion or contraction inside the upper cervicals or cranium will also be represented as a change in intracranial pressure gradients. Having said that, the source of increased cranial pressure could easily come from any one of the arteries supporting the neck and cranium. The intracranial pressure is also likely to increase if there's any malalignment of the cranial base bones on top of the cervical spine or the upper cervical vertebrae, such as a C0, C1, especially if one considers that the posterior vertebral artery has the challenge of completing two 90-degree turns on its journey from the cervical spine into the cranial basin. I'll be looking at that in more detail as we continue. The functioning of the glymphatic system in the cranium is divided into three stages. The first stage is the influx. The glymphatic influx happens inside the subarachnoid space as the CSF enters with the bulk flow into the periarterial space. The periarterial spaces surround the arteries that penetrate deeply into the parenchyma of the brain, and this is a convective flow. The second stage includes the CSF and ISF, the interstitial fluid. Movement inside the parenchyma water channels supported by the astrocytic end feet lining the periarterial spaces. This maintains ideal polarity and a protective sheath as fluid travels through the stage of the glymphatic system. This occurs via a blend of convective flow and diffusion. The third stage is the glymphatic efflux. It involves the drainage of the ISF into the perivenous spaces. Here, the neurotoxic and metabolic wastes re-enter the CSF or are transported directly by the meningeal lymphatic vessels, along with the cranial and spinal nerve lymphatic vessels. So this influx is occurring via various routes, which I'll go into more detail with the diagrams coming up. It's important to note that the glymphatic system runs in the same direction as blood flow, which is propelled by pulsations from the arterial vascular wall. The system can deliver protective molecules such as melatonin deep into the brain along the periarterial spaces. It also transports protein waste products such as amyloid and tau degradation products from the brain via the paravenous spaces. Here's an image giving a rendition of the glymphatic system. Some important aspects: we have the meningeal lymphatics, which are indicated here by the green. Then we have an artery below it with smooth muscle cells, so it has the ability to expand and contract. We have the venous sinuses in blue here, carrying CSF. The flow of the detoxification or the glymphatic system is moving from the arteries across to the venous system, and then we'll go down towards the lymph nodes and lymphatic structures of the upper cervical spine. This entire system is reliant on optimal pressure gradients. When it gets disrupted, then we have problems with these waste products that get left behind, leading to potential degenerative issues, cognitive issues. So the whole mechanism is convective forces and diffusion. So we're just going to cover a little bit about those meningeal lymphatics that we saw in the previous image. The glymphatic network is the result of the glymphatic system and the meningeal lymphatic vessels combining to provide detoxification and immune cell trafficking. It serves as a neuroimmune interface for the central nervous system and the brain. Two systems working in concert towards the same goals. The distinction of the glymphatic network from the glymphatic system is the fourth stage of fluid compartment transport with the action of the meningeal lymphatic vessels. This stage drains solutes, waste, and other signaling molecules directly from the CSF. Again, if we're looking back at this image, we can see the meningeal lymphatics at the top interacting with the venous sinuses, helping clean the cerebral spinal fluid, which is a different process than the diffusion convection that is occurring with the solutes and toxins, toxic proteins leaving the arterial system, moving towards the venous system, and this filtering of the interstitial fluid bulk flow, which is a metabolic byproduct of brain metabolism. This image reveals the meningeal lymphatic vessels. They occur at the vertex, but also exemplifies the organizational lymphatics at the cranial base. The only artery exposed here is the internal carotid artery, to which I'll elaborate on later. Recent research is highlighting the importance of a properly functioning lymphatic network in the role of preventing cognitive decline, such as Alzheimer's disease. So going back to this image, we have meningeal lymphatics interacting with venous sinuses. We also have them following around here towards the center, supporting the venous plexus and arterial plexus. And of course, the direction of the lymph is meant to be down and out of the cranium, whereby they'll be supported by the lymph nodes of the cervical spine. Some of the CSF will drain through the nasal turbinate. In terms of talking about Alzheimer's disease, the glymphatic system as it exists does not replace the drainage of the CSF through arachnoid villi into the venous sinuses, but may serve to augment and accelerate the clearance of waste products, especially proteins and other large molecules from the brain. Finally, the rapid removal of waste protein from the brain suggests that dysfunction of the glymphatic system may play a role in the protein deposition disease such as Alzheimer's disease and others. The meningeal lymphatic vessels are another pathway for cranial detoxification. They're delicate lymphatic vessels located around the spinal cord within the vertebral tissues, which help to drain all dural and epidural spaces as well. For the cranium, they act like a meningeal gatekeeper for central nervous system immunity, maintenance, and repair. With the discovery of meningeal lymphatic vessels, we now have additional drainage pathways for the cranium that drain directly into the deep cervical lymph nodes. Inside the cranium, the meningeal lymphatic vessels align next to large dural venous sinuses, cranial nerves, and meningeal arteries. The movement of lymph towards the deep cervical lymph nodes occurs via the foramina in the base of the skull. In regards to the lymph flow with the glymphatic system, or cranial lymphokinesis, excessive pressure limiting the vascular system will affect what we palpate when we look for cranial bone motion. The arterial flow into the cranium can influence temporal bone motion, a good example of why it is often referred to as the troublemaker in cranial osteopathy. The cranial base will limit cranial lymphokinesis via the jugular foramina and its role in venous drainage as well. The posterior vertebral artery occlusion can limit blood flow and increase cranial pressure gradients due to upper cervical spine dysfunction. If we have an issue with the arteries leaving the cervical spine into the cranium, that's going to cause a pressure issue inside the cranium. The cranial lymphokinesis is a global movement of lymph, blood, and CSF throughout the cranium and cervical spine. Regarding the characteristics of the temporal bone, I feel rather than viewing the temporal bone as a troublemaker, it's more of a canary in a coal mine, or an indicator of vascular insufficiencies. Also, the cranial base architecture includes the temporal bone. The most important factor in optimal cranial and cervical lymphokinesis is the concept of intracranial pressure and the limitations it puts on the glymphatic network and its ability for detoxification. Part of why the temporal bones are so influential in blood flow and cranial pressure is its articulation with the occiput and the sphenoid. Note the jugular foramen and the foramen spinosum. Also, any limitations to the jugular vein will impact pressure gradients within the cranium. We also have the passage of the internal carotids through the petrous portion of the temporal bone into the cranium. That's the principal vascular dynamic that'll dominate the conversation in terms of blood flow into the cranium. In this image here, we want to keep, here we have the foramen spinosum. We also have the jugular process. These are two key areas allowing for any obstructions in these areas. Of course, we have the articulation with the temporal with the occiput, or the temporal with the sphenoid. This can influence the pressure dynamics in the cranium, leading to lymphostasis and a compromised glymphatic network, and also limiting the flow of lymph to the deep and superficial cervical lymphatic nodes and support structures. This image allows us to see how the arterial vasculature forms a type of tree as it moves up from the sternum and clavicles to the cranium. If we just focus on the temporal bone and its role in supporting blood flow to the cranium, we can benefit from understanding the path of the internal carotid arteries. I'm placing importance on the temporal bones because they're part of the cranial base, and any limitation of motion affecting cranial PRM or alignment with the bones or upper neck will limit blood flow, and this can increase the intracranial pressure gradients. As a result of increased pressure, lymphokinesis will be limited. So this just also shows us that image of the tree and its branches as the artery comes up the cervical spine into the cranium. Here we can see the path of the internal carotid as it moves through the petrous portion of the temporal bone. And we can appreciate the branches of arteries that extend from the internal carotid as it makes its way into the inner cranium. The path of the internal carotid includes no less than 6 right angle bends. Starting with the carotid artery, as we're moving up vertically upwards below skull to enter the carotid canal, moving forward medially to the caroticotympanic branch of the middle ear, vertically upwards through the top of the foramen lacerum, forwards in cavernous sinus, inferior hypophyseal branch, going again vertically upwards medial to the anterior clinoid process and the ophthalmic branch. Here we got the going past the ophthalmic. Then it starts to go backwards on the root of the cavernous sinus. You have the superior hypophyseal and anterior choroidal branches. Then it goes upwards slightly backwards to the terminate posterior communicating branch, and branches off to posterior communicating artery, anterior communicating artery as well. Even though we are focusing on the cranium and cervical spine in regards to pressure gradients, just some information related to the whole body. In the foot of a standing person, the arterial blood pressure is about 200 mmHg, but the venous return flow is less at 100 mmHg. The pressure in the venous system steadily falls the closer it gets to the heart. Lymph pressure is lower in the peripheral lymph vessels, and it elevates centripetally until it reaches its maximum at the thoracic duct. Now that's the thoracic duct entrance is the abdominal confluence of lymphatics as well, which is underneath the left lobe of the liver, next to the aorta, around the celiac plexus. So we need to keep that in mind. Lymph flow back to the thoracic duct and venous angles must pass through various tissue pressures. I cover this a little bit more in the next presentation on the mediastinum, but the thoracic duct travels through the mediastinum up to the venous angles. So any issues surrounding the mediastinum or the diaphragm or the liver or the stomach will impact the dynamics and the ability for the thoracic duct to retain its shape and tone. The more tissue pressure, the more resistance to lymph flow. Arterial pressure will cause surrounding tissues to reflect the pressure imbalances, meaning that you will get edema in the area. This involves the interstitium as well as various fascial layers and connective tissues. Continuing with the emphasis on pressure gradients, let's look a little more closely, specifically at the intracranial pressure dynamics. Moving back to the cranium and the topic of increased intracranial pressure. Intracranial pressure has an influence on the lymphatic fluid transport system. The intensity of the intracranial pressure has been shown to impact the lymphatic system. This was often accompanied by cerebrovascular occlusion, which led to decreased cerebrovascular pulsation. In addition, there was also interruption of the lymphatic flow from the dorsal meningeal lymphatics as well as the deep cervical lymph nodes. So that connection gets stifled when there's too much pressure. It's harder for the meningeal lymphatics to move the lymph towards the deep cervical lymphatics so that it can move its way down to the rest of the body. The impacts are directly related to the intensity and duration of the intracranial pressure, as well as the pressure on local pathways of detoxification. It's also been noted that increased intracranial pressure is reflective of an increase of arterial wall thickening. This brings us to the selfish brain hypothesis of hypertension, where they've observed the thickening of cervical arteries feeding blood up to the brain. When the pressure inside the cranium is increased, it creates a natural resistance to blood flow entering the cranium from the cervical arteries. The result is a narrowing of arteries to increase the force of blood flow into the cranium. Of course, this cannot happen without the rest of the body being recruited, and this recruitment and increased blood pressure is defined as essential hypertension. So I think what often gets missed in essential hypertension, it is a full body response. It's possible that it could be responding to this selfish brain hypothesis. Increased blood pressure could also be occurring for other reasons. If there are organs where there's too much pressure surrounding organs, limiting their function, the body's naturally going to increase its own blood pressure to try and fulfill its role of delivering blood to all aspects of the body. In this case, it seems like the body is prioritizing the brain, and there is a self-defense mechanism in this selfish brain hypothesis. So let me talk a little bit more about this selfish brain. In the selfish brain hypotheses, in cases of reduced blood flow to the brainstem, known as hypoperfusion, there's a notable onset of sympathetic hyperactivity and hypertension. So the nervous system is responding to the reduced blood flow, supporting the brainstem. This is referred to as the Cushing mechanism, or the selfish brain theory. Any cerebral blood flow limitations to the circle of Willis or vertebral artery can lead to hypertension or increased systemic blood pressure. It is generally believed that it is the development of mechanical or structural resistance that occurs elsewhere in the body prior to the development of essential hypertension. So what they're suggesting here is that the limitation doesn't necessarily have to be occurring in the cranium, but can be. But that there are mechanical or structural issues creating resistance or densities to blood flow, which increase pressure gradients in the body, which will directly affect the blood flow going up to the brainstem, thus creating a vicious cycle where the sympathetic nervous system kicks in to try and stimulate more blood flow to the brain. Continuing on with the recent studies by Phillips, he goes on to say, in 1990, Dixon wrote an article reappraising the importance of the Cushing reflex for blood pressure stabilization. In this article, he stated that a restriction of blood flow to the brain can produce sustained hypertension. Dixon also stressed that fact that the Cushing response begins when intracranial pressure begins to rise and is still within the physiological range. He described the Cushing reflex as the most powerful neural blood pressure stabilizing system involving the self-protection of the brain. Dr. Harvey Cushing discussed the concept of a Cushing reflex, describing the response of the nervous system to acute elevation of intracranial pressure. There are 3 signs that he uses to support his conclusions. We have a widened pulse pressure with increasing systolic and decreasing diastolic. We have bradycardia and irregular respirations. He surmised that a dramatic increase in blood pressure was a reflex of ischemia at the brainstem with patients who had increased intracranial pressure. Central perfusion is defined as the rate at which blood and lymphatic flow exits the cranium. So here we're going to have impact on the glymphatic, lymphatic systems when this Cushing reflex comes into play. So an overloading of or an activation of the selfish brain mechanism, which can also be described as or observed as essential hypertension, has the ability to impact the detoxification pathways of the cranium. Just finishing up with the Cushing mechanism, as increased intracranial pressure increases, the cerebral perfusion decreases unless there is a compensatory increase in systemic arterial blood pressure. This contributes to essential hypertension. The body must adjust systemic arterial pressure to compensate for decreased cerebral perfusion. It has been known since 1948 that people with essential hypertension had increased cerebral vascular resistance. Increased intracranial pressure leads to increased sympathetic activity by as much as 17% and is associated with an elevation of systemic blood pressure. Another result of increased intracranial pressure will be venous congestion, which often can be accompanied by anxiety and headaches. Now let's look a little bit at some of the palpation tips for lymphostasis around the cranium. These tips are coming from Osteopathy Kuchera. A simple way to determine if there is any lymphatic congestion present in the cranium, including the ear, the nose, and throat passages, is to palpate the supraclavicular tissues and look for somatic dysfunction presenting as a fullness of the tissues. That's the area above the clavicle. In addition to this area, it's important to palpate the posterior cervical, the preauricular, postauricular, submaxillary, tonsillar, and sublingual lymph nodes to determine if there's any infection or swelling. So just some possibilities of what's contributing to the intracranial pressure. Vascular insufficiency going into and out of the cranium, including internal, external carotid, and posterior vertebral arteries. Cranial-based dysfunction reacting to the individual birthing experience, involving the position or mobility of the occiput, temporal, and sphenoid. Upper cervical spine lesions of individual segments out of physiological relation to other spinal segments, which will limit blood flow. Intraosseous related to direct trauma or impact on the bones of the cranial base. Spinal dysfunction between segments of non-physiological with or without axis nature are also going to limit blood flow. We have the cervical-thoracic junction at Chassenac's tubercle. And we also can have excessive pressure surrounding the venous angles within the mediastinum, which I cover more in the next presentation on the mediastinum. We also know, because of the selfish brain mechanism, that there are other aspects of the circulatory system in the body that could be compromised that would increase pressure. Those can be contributing to congestion and inflammation as well. But since we're just dealing with the cranium and cervical, let's talk a little bit about the inflammation regarding the cranium and the cervical spine and its impact on detoxification. Inflammation in the cranial lymphatics. Osteopathic guidance informs us that chronic infections within the cranium can lead to adhesions in the mucosal passages, which will inhibit the health potential. For example, glaucomatous changes have often been connected to poor lymphatic drainage of the eye. When there is a reduction in the absorption of endolymph inside the inner ear, it can end in fibrosis of the end lymphatic duct and lead to tinnitus, vertigo, and diminished hearing. In regards to head and neck congestion and inflammation, in many cases of extreme amounts of congestion in the head and neck due to viral infections, it's not just the virulence of the virus but also the amount of obstruction that exists in the blood and lymph vessels. That comes in the form of narrowing of vessels or increased intracranial pressure. Microorganisms will readily overtake tissues if the tissues are lacking in vitality due to poor oxygenation of the blood. So this is an example of the lymphostasis that will occur and a buildup of toxicities. And in the head and cranium, it's those toxic tau proteins, for example, that are directly linked to neurodegenerative issues. When blood circulation is impeded, it is likely to lead to nodal induration, hardening, and the toxins will have an impact on the resident nerve centers due to the congestion present. When tissue is devitalized due to restricted or blood circulation, it will be readily available for the inception of viral presentation. And this is coming again from Osteopath Millard over 100 years ago. This is the perspective coming from Foldy on cervical lymphostasis and inflammation. Prolonged irritation and inflammation around the brain can lead to a breakdown in the blood-brain barrier, as substances such as transferrin and serum albumin can be found in the brain tissues. This is an indication of the lymphatic protein load in the brain being elevated and leading to toxicity and degeneration of tissues and neurons. Cervical lymphatic blockage can contribute to a combination failure in the brain, as any increase in lymphatic load will intensify the condition. So this includes systemic lymphatic load. So if you are having issues in any other parts of the body with edema, and we're not just talking about lymphedema, but just basic edema, holding water, this is going to have an impact on what goes on in the neck and the head, because it does increase toxicity overall in the body, and everything is connected together. So hence, I don't want to just isolate the cranium and cervical area from the rest of the body, especially when we're talking about the selfish brain theory. It's important to continue looking at the entire vascular tree mechanism. If we want one aspect of the tree to improve, we have to ensure that other aspects of the tree are open and available to deliver blood and to sustain normal pressure gradients through the body. The more normalized or optimal blood flow we have, the more likely that lymphokinesis will occur normally. Lymphostasis and inflammation continued. Tissue degeneration will be the result of prolonged inflammation, as well as smoldering infections and tissue destruction brought on by chronic inflammatory processes. There's also evidence that the removal of cytokines, leukotrienes, prostaglandins, bradykinin, and histamine are all dependent on the proper function of the lymphatic system. Intracellular edema will cause destructive changes to cell nuclei and lysosomes, as well as destroying swollen glial cells. The myelin will also become irregular, and fat droplets will begin to appear next to the blood capillaries and in the cells of the choroid plexus. The role of microglial cells in the brain is in sensing changes in the internal milieu of the brain in order to manage pathogens and toxicity, helping maintain local homeostasis. Toxic metabolites lead towards neurodegeneration and cognitive decline. Going back to that whole idea of inflammation and detoxification, if we just take the figurative example of the lymphatic system, note that the artery and the vein are just generalized. They're not any specific, so this doesn't apply to any particular part of the anatomy of the skull, but you could assume closest rendition would be temporal bone, if due to the proximity of the artery and the veins and the size of the artery. Nevertheless, what's important here is this topic of inflammation and tissue degeneration. This is the environment, and that is vulnerable to all those aspects. And so we do know that endothelial cells are like, for example, in the neurovascular unit below, they're part of the structure of the surrounding the neurovascular. So that can break down. A lot of the degeneration happens in the endothelial layers, and so obviously most of these structures here are going to be comprised of endothelial layers as well as support for the particular nerves. So when this mechanism starts to break down, we start getting tissue degeneration. That further breaks down the ability for this process to occur. So you can see why the progression of neurodegenerative issues is such a challenge to resolve, because once you start getting damage to the mechanism or the tissues within this realm, then there's no repair going on. It just continues to create more inflammation in a vicious cycle. With the theme of detoxification, lymphostasis, and inflammation, we have to quickly contribute the microbiome bacteriophage metabolite axes, MBMA, also known as a gut-brain axes. There are examples of certain gut bacteria leading to the apoptosis of microglial cells in the cranium. The microbiome bacteriophage metabolite axis begins to deregulate with aging. The loss of function is due to the increased levels of inflammation. So I would argue that regardless of where you stand in the aging process, significant amounts of inflammation will likely also contribute to microglial cell apoptosis. Shifting gut metabolites to fit the personal pathology appears to improve the regulation of microglial cells and has an effect on gene expression. The microbiome bacteriophage metabolite axis is a complex interplay between the gut bacteria, their viruses, which are the bacteriophages, and metabolites they end up producing, and they all impact host health. The axis is good for highlighting how changes in the gut microbial community can influence the bacteriophages, which will alter the production impact of bacterial metabolites within the host. But they are all interconnected. Changes in the phage population can alter the bacterial community, leading to shifts in metabolite production that in turn influences host health, including brain function, immune response, and even susceptibility to diseases. The inflammation aspect is also important, in particular with myelin, because we've got nerves supporting all aspects of function in the cranium, and all of them require a healthy coating of myelin in order for them to function. What we know is after a short period of time, swelling from inflammation will create gaps between structures that initiates collagen deposits, causing further swelling of blood capillaries and endothelial cells. Increases the pressure. This pressure obstructs the lymph, and it can also lead to hemangiopathy around the optic nerve, the retina, and further fragmentation of the myelin supporting those nerves. This has implications with recent studies on multiple sclerosis as well, and the participation of the failed lymphatic support around certain nerves of the cranium and upper cervical spine. And as I say, myelin is a fatty insulating substance that forms a sheath around nerve fibers, particularly the brain and spinal cord. And they call it a myelin sheath. It's crucial for the efficient and rapid transmission of electrical impulses along nerve cells. Without myelin, nerve cells, they travel much slower and become unpredictable, and it can lead to various neurological disorders. Just to emphasize the aspect of myelin regeneration, and inflammation. This image gives us a good indication of how the lymph vessel and the spinal nerve and the spinal ganglion are all interconnected, and how the lymph is supporting the nerves as it's leaving the subarachnoid space in the regions of the spinal nerves. And obviously that's going to be following each nerve that's exiting the subarachnoid space. So let's move on a little bit to another aspect of managing inflammation and supporting the detoxification aspects, or the lymphatic aspects of the cranium and cervical spine, in particular the cranium. And that's discussing aspects of the microbiome and its supporting role. The oral microbiome is also known as the oral microflora. The phrase microbiome was coined by Joshua Lederberg in his description of the community of symbiotic, commensal, and pathogenic microorganisms that inhabit our bodies on many levels. The oral cavity contains distinct regions of flora that include the gingiva, the teeth, tongue, the sulcus, the cheek, lips, soft palate, and the hard palate. Additionally, it's important to note that the flora continues into the tonsils, pharynx, esophagus, and into the eustachian tubes. As I mentioned in my part 2 lympho vascular dysfunction presentation, this is where we get into the mucosal aspects and the mucosal associated lymphoid tissue, which is lining pretty much all the tubes in the entire body, from head down into the pelvis. So mainly it just changes its name as it travels through the body, and so I'm not going to cover it in high detail here. Oral bacteria dysbiosis is directly linked with heart disease, diabetes, lung inflammation, systemic disease, endocarditis, and tonsillitis. And I think mostly the connection here is because that all those areas are connected through those mucosal and endothelial linings. All of those areas do have a microbiome. They also have the precursors to the lymphatic system with the macrophages and the various cells that are in the endothelial linings. Just a little more on the brain-gut microbiome axes. Recent studies indicate that bacterial DNA can be isolated inside the closed environment of the human brain. This implies that there may be a brain microbiome. It also appears that there is a bacterial diversity between the cerebellum and the hippocampus. Also, the specific microbiome populating the brain is partly determined by the composition of the gut microbiome. And according to Westphal, dysbiotic microbiota in the gastrointestinal tract promotes and aggravates neurodegenerative disorders. This includes Alzheimer's disease. It's been shown to correlate to dysbiotic bacteria and the immune, metabolic, and endocrine abnormalities associated with abnormal gut-brain axis signaling. Recent reports also indicate that brain dysbacteriosis may play a role in Alzheimer pathogenesis. There is an apparent bidirectional activity between the brain and gut microbiomes that involves the central nervous system, gastrointestinal system, and immune system interacting. The brain can affect the community structure and function of the gut microbiota through the autonomic nervous system by modulating regional gut motility, intestinal transit and secretion, and gut permeability. A lot of that is going to be completed via the vagus nerve. Evidence also points to an eye-gut axis and the effects of gut microbiome of optic nerve myelination. Gut function is regulated by the autonomic nervous system as it controls regional motility, secretion of gastric acid, mucus, bicarbonate, gut peptides, epithelial fluid maintenance, antimicrobial peptides, mucosal immune response, and intestinal permeability. The autonomic nervous system helps modulate microbiota activity and composition. Small intestinal bacterial overgrowth is an example of slower gastrointestinal motility, slowing down transit rates of stool. This results in less beneficial bacteria in the gut. Now, of course, that's not the only thing that contributes to bacterial overgrowth. If you have a poor diet, then you will certainly, regardless of the motility that's going on in the small intestine, you will most certainly have a problem with bacterial overgrowth. Moving away from microbiome back to the cranium, we're looking at cerebral spinal fluid and the lymphokinesis dynamics. One animal experiment involved removing cerebral spinal fluid from anesthetized mice and replacing it with an equal volume broth of Staphylococcus bacteria. It took less than 5 minutes after the injection to observe many bacteria that were taken into the cervical lymphatic vessels. So this is a connection of the cerebral spinal fluid connecting to the cervical lymphatic vessels. Other experiments indicated that substances once injected could be observed in the nasal cavity, the cervical lymph nodes, and even the lymphatic vessels located in the conjunctiva of the eyes. Here's the classic image just showing the relationship of the venous sinuses and the movement of cerebral spinal fluid through the various plexes. It also includes the arachnoid granulations. And as you can see, the cerebral spinal fluid accompanies the spinal cord going all the way down to the sacrum. And what's not shown here is how the lymphatic system will actually, the cerebral spinal fluid will actually drain towards the nasal turbinate and connect with also the upper cervical lymph nodes. So that's an excellent way to support the detoxification of the cerebral spinal fluid itself. And this does not include the meningeal lymphatics, which I'll put in, which would be roughly there. So let's talk a little bit about one aspect, the cranial safety valves that are part of the glymphatic system. In terms of cranial lymphatic safety valves, the cranial lymphatic system also has a safety valve mechanism that protects the subarachnoid space. Experiments with mice indicated that once the pressure in the subarachnoid space increases with the fluid injection, then the jugular trunk will increase its volume of lymphatic fluid to compensate by decreasing cranial fluid pressure. So we have an adaptation of the jugular trunk widening in order to balance out the pressure that's occurring in the subarachnoid spaces. The arachnoid granulations also act as a backup safety valve. This image shows the venous sinus system of the brain, showing superficial and deep veins. And in terms of that safety valve mechanism that I was discussing earlier, here at the jugular is where the any alteration in pressure affecting the smaller branches we'll end up with the expansion of this jugular trunk to compensate for it. This allows for adequate exit of blood leaving the cranium and also decrease in the pressure gradients. Just to finish off with the glymphatic system before we move on to the actual lymphatic system and lymph nodes supporting the cranium and cervical spine. Another reminder here of the venous system. This gives you a little more of the superficial tributaries, and of course you have the jugular here where we get that expansion and that additional safety valve mechanism which contributes to the glymphatic network and optimization of detoxification and nourishment of the brain and the spinal cord in general. So let's move on to cervical and cranial lymphovascular terrain. Moving away from the glymphatic system per se, we're now going to connect the lymph nodes supporting the cranium, moving down through the cervical spine that eventually connect into the mediastinum. The lymph channels live under the same laws that govern the circulatory system. Any lesion that contributes to the contraction of muscular tissues will eventually obstruct lymphatic channels and blood vessels. Obstruction precedes congestion, and prior to the successful existence of invading toxic substances resulting from the presence of a virus, there must be suitable soil to protect compromised tissues. This is going back again 100 years to the osteopath Millard. I like his language here when he talks about looking at the immune aspect or the terrain aspect as being a type of soil, and it needs the right constitution of healthy cells and bacteria to properly defend the body. And of course, I think there's also a vicious cycle that can occur. So although obstruction can precede congestion, I think that congestion can also cause obstruction. So vice versa. So it is a chicken or the egg scenario. Just continuing on with Millard's perspective. Thus, we see first, last, and always the greatest preventative measure in infection of any nature will be the maintenance of normal circulation both in the lymph channels and in the blood vessels. Muscular tension or vertebral lesions will end in obstructed lymphatic flow due to the arrangement of the lymphatics in the head and the neck area. Although there's a deep superficial system of lymphatics at the upper cervicals, it is possible to have one or the other respond to a throat infection before the other is affected. Prior to addressing any lymphatic disturbances in the head, it's imperative that we look to clear away any obstructions to lymph flow anywhere in the body. Now that is a general statement, and it's challenging if you have someone coming in that is presenting with lymphatic congestion symptoms in the cranium. But I think what he means here is that we do need to ensure that the direction of lymph, which is back down to the venous angles into the mediastinum, that area is also available to receive the lymph. So in my estimation, that's where we would be looking at. I cover that in the next presentation in the mediastinum. We have to consider the pressure gradient imbalances that might be limiting the flow of lymph back to the venous angle. So it may not just be a local issue occurring in the cervical spine. Here we have an image depicting the superficial lymph nodes supporting the parts of the cranium, jaw, and throat, tonsils. Keeping in mind, these are all working as a chain, like all other lymph nodes, and the destination of the lymph is back towards the venous angles against the pressure of the heart and lungs. And this image, it is good to note the size differentiation between different lymph nodes. For instance, the lymph nodes around supporting the tonsils, they are a little bit larger And as I say, then the trend of the lymph is down towards terminal point at the venous angles. And keep in mind, this image does not include the vascular, the arterial, the aortic arch, the subclavian and carotid turning into the internal carotid. And it doesn't involve it doesn't show us any of the nervous system. It's important also to note that there are actually hair follicle lymphatics. Stem cells located in hair follicles manage the behavior of lymphatic capillaries in the skin by secreting molecules that act as an on and off switch for drainage. This allows them to manage the composition of fluids and cells in the surrounding locale and ultimately synchronize regeneration across the tissue, including hair follicles. This allows for the consideration of the role of lymphatic system in managing hair loss and regeneration. We can also look at lymphatics that support the tympanic cavity, which are deeper lymphatic structures. The tympanic cavity lymphatics contain both mucosa and lymphatic vessels. So those are as a double layer of immunity in the cavity. One example of the connection of mucosa to the venous system. There are smaller groups of veins traveling from the mucosa of the mastoid antrum, terminating in the superior petrosal sinus, and they represent a potential path of infection from the mastoid antrum to the meninges. The lymphatic vessels in the tympanic cavity and antral mucosae both drain to the upper deep cervical lymph nodes, and you're going to see that the upper deep cervical lymph nodes are a transitory point for most of the lymphatic system that is supporting nodes, superficial and deep, to the cranium and upper cervical spine. The mucosa travels via the pharyngotympanic tube to cover the ossicles, muscles, and nerves inside the cavity. It also spreads to the mastoid antrum and the local air cells. The middle ear has secreting respiratory mucosa with tiny cilia in the surface. Also, when there's a reduction in the absorption of endolymph inside the inner ear, it can end in fibrosis of the end lymphatic duct and lead to tinnitus, vertigo, and diminished hearing. The lymphatic drainage of the teeth occurs ipsilaterally at the respective submandibular lymph nodes, which is also a hub for the oral cavity, facial bones, and nasal cavity. Lymph nodes from the oral cavity drain into the submandibular and jugulodigastric nodes. The tongue contains lymphoid follicles embedded in the mucosal layers. The tongue has a great variety of functions and has the greatest number of lymphatics, nerves, and vessels of any organ of its size in the human body. The drainage from the back of the tongue is interconnected with the drainage of the tonsillar region, and this will enlarge certain lymph nodes when responding to colds or sore throats. This is another great image from Foldy, giving us an example of the deeper lymph nodes that are supporting the mucosal layers of the epithelial lymphatic cellular network and mucosa. So you can see what we ingest or breathe in requires constant surveillance. And of course, the direction of lymph flow is back down towards the larger lymph nodes and then eventually down, exiting the head and neck to the venous angles. And also we know that in the nasal turbinate that there is that exchange of CSF that is also making its way into the lymphatics and the capillary layers in the mucosa, the nasal septum. coming back to this image just to remind us that the deeper lymphatics will eventually make their way to the superficial lymphatics and down through the cervical spine. In regards to the nasopharyngeal lymphatics, there are lymph areas for the nasopharyngeal region, the fossa of the nose, and the eustachian nodes. Prior to reaching the deeper cervical nodes, the lymph will pass through several channels of subparotid nodes. There will be a backing up of lymph if the cervical nodes have previously been overburdened, and this will cause the retropharyngeal nodes to enlarge from the tissue congestion. That would be the scenario for tonsils to become swollen because they are overwhelmed, as they do participate in the immune system filtration and are essentially part of the lymphatic system. The lymphatic network of the nasal mucosa drains in a dorsal direction towards the deep parapharyngeal lymph nodes, and a smaller portion of lymph drains in the rostral direction directly into the sublingual lymph nodes. As I've mentioned, research has indicated that there is a clearance of cerebrospinal fluid through the cribriform plate into the nasal turbinate region and its lymphatics. The activity is mostly in the middle nasal turbinate. This lends to the acknowledgement of a brain-nose interface for the clearance of CSF via the extracranial lymphatics. This also includes lymphatic movement along olfactory nerves leading to the nasal turbinate as well. Cranial and cervical lymphatics are the major outflow pathway for CSF, according to the studies they've done with mice. Lymph moves to the nasal mucosa prior to entering the nasopharyngeal lymphatic plexus. That acts as a hub for the CSF drainage to the deep cervical lymph nodes. And again, just coming back to the image we saw earlier of the nasal turbinate and the submandibular lymphatics, and just reminding us of how interconnected everything is. Let's move on to talk about ocular lymphatic vessels. The conjunctiva of the eye is a transparent and thin mucous membrane. The mucosa of the conjunctiva extends into the nasal mucosa, which is relevant from the point of view of infections spreading and things like allergic reactions in connection with eyes watering and runny nose. The conjunctiva mucosa contains mucosal associated lymphoid tissue. So this is that same tissue that travels through pretty much from head to pelvis, and it's just the name changes as it goes through different segments of the body. The conjunctiva is only part of the orbit that has lymphatic drainage. Ultimately, lymph from the ophthalmic venous system supporting the conjunctiva drain into the pre-auricular and then the submandibular lymph nodes. So we looked at those submandibular lymph nodes in the previous image. Getting back to that vicious loop of what comes first the infection or the adhesions. Chronic infections can lead to adhesions in the mucosal passages, which will inhibit the health potential and detoxification pathways. For example, glaucomatous changes have often been connected to poor lymphatic drainage of the eye. Again, just a reminder, in instances of glaucoma, it's one thing to consider that there's a poor lymphatic drainage, but what's causing the poor lymphatic drainage is likely going to be connected more to the vascular system, meaning that pressure around the supporting arteries is impacting the ability for an area to drain. The increased pressure can also be having an impact on any of the sheaths which connect to optic nerve for the eye, and in general the increased pressure in the cranium will certainly have an impact on blood flow to the ocular lymphatics as well. In a recent study with mice who had a right eye intracranial injection tracer, it was found to take anywhere from 20 minutes to 6 hours for the tracer to arrive at the cervical and submandibular lymph nodes. Experiments with a mice model in a new gut retinal axis indicated that certain T cells require a detour to the gut in order to be able to gain retinal axis, which is quite interesting. Currently, most therapeutic strategies for managing glaucoma revolve around decreasing elevated intraocular pressure. Although the mechanism is still unknown, there's a role for T cells in glaucoma pathogenesis. So this is a new area of research, but it is fascinating to consider that this gut retinal axis and how there needs to be a circular flow, at least of certain T cells that are coming from the gut in order to support retinal health. Moving away from the ocular to the oral lymphatics and Waldeyer's rings, there's an abundance of lymphatic tissue in the form of lymphoepithelial cells in and around the tonsillar ring, and the tonsils are considered as secondary or peripheral lymphatic organs. Waldeyer's rings are a layer of lymphoid tissues which are circumpharyngeal around the entrance of the upper digestive and respiratory tracts. There is an additional layer of lymphatic tissue called MALT, which is also part of Waldeyer's rings. In the first inner circle of Waldeyer's rings, the lymph can collect here and pass through nodes that are interconnected with the cervical lymphatic chain. There can also be a disturbance in the tonsils if there are enlarged lymph nodes at a lower point in the neck, which contributes to a lymph backup reaching the tonsils and accompanying tissues. Once again, it's important to ensure proper drainage of lymph into the subclavian veins. The vascular composition of the tonsils is unique in that there are 4 branches of the external carotid artery that supply each gland. When the veins of the tonsils are compressed due to scar tissue, local muscle contraction, or congestion, there will likely be a lymphatic stasis around the tonsils. It's just an image that represents the different aspects of connecting the lingual tonsils, pharyngeal tonsils, tubal tonsils, and palatine tonsils, and they are connected in a ring through the mucosal layers. Back to this familiar image, and I would suspect the Waldeyer's ring is going to be occurring somewhere around this aspect of the anatomy, and note that again the support from the deeper lymphatics of the cervical spine as the first layer of defense does need somewhere to drain to. Looking specifically at laryngeal lymphatics, when the nodes become enlarged, they can press on the recurrent laryngeal nerve and present as a laryngeal cough or laryngitis. Keeping in mind, as I talked about before, the idea of the itis component, which is a chronic issue of lymphostasis. Treatment of the nodes has an impact on resolving the pressure on the laryngeal nerve. We can also consider that in some cases a goiter is the result of a lymphatic drainage disturbance. The mucosa located at the vocal cords is the demarcation line between the upper and lower lymphatics of the larynx. The upper lymphatics exist at the base of the tongue along with the supraglottic vessels. They both accompany the superior laryngeal artery through the thyroid membrane to finally drain into the upper deep cervical lymph nodes. Here's another excellent image from Foldy, coronal view of the upper neck and jaw area minus the mandible. Here we have the tongue. You can note all of the small lymphatic tributaries inside the tongue. Then these are connecting to the deep cervical lymph nodes. We also have support of the submandibular lymph nodes underneath, and the submental lymph nodes. And obviously here in blue we have the jugular and internal carotid coming up. And then we also have here some jugular lymph nodes positioned between the carotid and the jugular. This image allows us to see how the associated lymphatics organize within the constrictor muscles and tissues. And consider these deep cervical lymph nodes. They're retropharyngeal, and they're behind the trachea and the esophagus. So a couple things we want to appreciate is the fact that these upper cervical, or lymph nodes that would be considered upper cervical, are a little bit larger, and they get a little smaller as you get in towards the center of the constrictor muscles. And we can see how they accompany the internal jugular, and also all these the sympathetic trunk cervical ganglia coming down as well. And then I believe this is a vagus nerve here, and there are lymph nodes directly correlated with the vagus nerve before it heads down towards the aortic arch, and then depositing here into the thoracic duct as terminus for each side. And what else can we look at this image? Yeah, so these are, as I say, these are deep, and these do not include they're connected to the deep cervical lymph nodes, but they are in their own specific layer. Moving on to thyroid lymphatics. The thyroid has drainage upward, downward, and in a lateral direction away from the gland to supporting lymph vessels. Drainage of the thyroid can also be supported by resolving osseous lesions in the upper thoracic spine, cervical spine, as well as the clavicle. The lateral thyroid drains into the deep cervical lymph nodes via the superior thyroid veins. Thyroid lymphatics may also drain directly to the thoracic duct. The superior and inferior thyroid arteries provide the thyroid blood supply, and the lymphatic vessels of the thyroid communicate with the tracheal mucosal plexus, which connects to the prelaryngeal nodes. Lymph vessels and regional nodes of the thyroid gland. This image helps us see the number of lymph nodes embedded in thyroid tissues, how they connect to the chain of nodes surrounding the thyroid. So, as I already mentioned, we have the thyroid connecting to lymph nodes on either side. This is obviously on the right side, carotid and jugular. We have nodes that are connected upwards and nodes that are connected downwards. And I suspect there are nodes on the other side of the thyroid itself, on the posterior side of it, and lateral to this side. So that's all because of the design of the lymphatic system. Like down here, you can see how these nodes are all interconnected like a chain. And then another thing that's of note here is the supraclavicular lymph nodes, a little bit larger than some of the tracheal lymph nodes supporting the ring cartilage. But you could see why Millard would speak to resolving osseous issues in the clavicle to help support lymphatic drainage in the area. Tracheal lymphatics. The trachea has a mesh network of mucosal lymphatic vessels which are transversely oriented in the region of the tracheal cartilage. Along the membranous wall, the mucosal vessels are longitudinally oriented. The mucosal plexus has short collectors that perforate the membranous wall sections. This image gives us an indication of how the lymph nodes are organized when you remove the thyroid. And as you can see, we have lymphatic support for the trachea and the ring cartilage. And we can see how these lymph nodes are connected to the lymph nodes of the carotid artery and the internal jugular. Moving from here, let's move down in towards the mediastinum, so following the lymph nodes going down into the lungs and bronchia. So going in the direction into the mediastinum, this is just a brief overview, just for us to appreciate how the cervical and cranial lymphatic system does interweave with the, for instance, with the mediastinum. And then the next presentation is focused primarily on the mediastinum and gets into higher detail. Bronchial and lung infections are most commonly manifesting via the throat, and very rarely do they occur from any other source. When the cervical lymphatic glands have been blocked, there will be an enlargement of the bronchial glands, followed by the involvement of the nodes located at the root of the lungs. If the lymph vessels and nodes are not properly cleared into the ducts and subclavian veins, there will likely be a downward passing of infection. So this is why I think it's important to look at how the lymphatics travel from the head and the neck down towards the mediastinum, which we'll go on to show now. This image shows us how the deep cervical lymph nodes connect to the deeper chain of nodes of the mediastinum. This chain of nodes continues to travel down to all the way past the diaphragm to the celiac nodes. But most of the lymph doesn't go down in that direction. Even though we are following the lymph down through the body, let's keep in mind that the lymph is primarily moving up towards the venous angles and moving in towards the thoracic duct. So this image is giving us the pericardium and some of the lymph nodes that are supporting the pericardium. Here in gray we have the pericardium. So the thoracic duct is coming through here, and of course it starts down from below the diaphragm next to the aortic arch. The entrance to the thoracic diaphragm is here, and then it's going upwards. But a lot of the nodes that are deeper, like these inferior tracheobronchial nodes, they'll drain directly to the thoracic duct here. They're not connecting necessarily just with these nodes and then carrying up to the terminal angle of the thoracic duct. So the lymphatic system is, this is the deeper lymphatic system that we're looking at. These are not superficial nodes, including the ones down in the celiac nodes. This image, we can see the regional lymph nodes without the heart and pericardium. Note the connection of lymph nodes extending again down to the diaphragm muscle itself. So one might imagine how potential heart condition resulting in pressure gradient imbalances could lead to lymphostasis in the area. Also, deep in this myriad, we can see the thoracic duct, which carries lymph from the lower extremity. So again, here's the thoracic duct coming up through the center. So we remove the heart in this image, and again, and then we have the diaphragm here, and you can see the chain of nodes. There's not as many of them in this area here as they connect, but when you get into the bronchi, you can really start to see how many lymph nodes are just even surrounding the bronchi. If we just go in towards the lungs, this image allows us to see the flow of lymphatics away from the deeper portion of the lungs, from the alveoli. So the alveoli is the last place that the lymphatics touches when it comes to dealing with supporting the lungs. But, you know, the lymph vessels do come in. You can see this rendition here. There are lymphatics that are associated. So anywhere you have blood flow, you've got lymphatic flow. And although there's no lymph in this particular part of the alveoli, the distal part that makes the most contact with with oxygen, you can see that the venous system is definitely, again, supported. And then we also have that subpleural lymph vessels when you are looking at the pleural layer as well. So at almost every layer, there's lymphatic support. And again, we can see the lymph here accompanying the bronchus as well. And it doesn't give a lot of lymph nodes, but these are the lymph vessels. Again, for the sake of not disconnecting the cervical and cranial and lymphatic system from the rest of the body, we have the deep lymphovascular train connections. Cranial and cervical lymphovascular train is continuous with the deeper lymphatic structures of the mediastinum. As the structures of the mediastinum continue down below the diaphragm into the abdominal cavity, but keeping in mind that's not the direction of lymph flow. So we're taking into consideration that we have lymphatic and glymphatic aspects that are moving lymph down towards the terminus at the venous angles. We also want to keep in mind that the direction of lymph from the bottom is coming up. So here we have the sternochyly and the beginning of the entrance to the thoracic duct, and that thoracic duct will travel up and branch off it to the venous angles. We also have lymph coming from specific nodes of the mediastinum superficially to the thoracic duct. And then some of these other deeper lymph nodes will also travel out superficially because of the way the chain is oriented. And of course, we also have lymph nodes that are connecting with the diaphragm. And then what we don't have in this image is the liver, which is a little bit different in terms of how the lymph behaves around the liver, which I've described as more of a lymphatic hub where we have multiple directions of lymph, but I'm not going to cover that in this image. So more of a full body image, and again we want to remember that the dynamics above the thoracic diaphragm and the terminus for lymphatic system at the thoracic duct, we want to keep in mind the direction of lymph flow is coming from the periphery through the center and up. And what we don't have in this image here is the addition of the diaphragm, which would be somewhere around there. And of course, we want to also remember that we have the aspects, pressure gradient aspects of negative pressure occurring here in the upper, this the heart that I'm putting in here, above the diaphragm we have negative pressure. Below the diaphragm we have positive pressure. The idea is that the lymph is supposed to move from periphery up, and this area here at the epigastric area is critical piece because it has the diaphragm, the tone, depending on the position of the diaphragm and the tone in the epigastric area, that'll affect thoracic duct, which we know can be impacted and can distend and expand under pressure. And then that's going to affect the entire lymphatic system. So even though we're focused on head and lymphatic system, that doesn't mean that the solution to resolving lymphostasis related problems is only going to be found in the area of complaints of symptoms, for instance, headaches or skin issues occurring in the psoriasis, those types of things. We do have to consider that we have an interconnected system. So if the pressure gradients are off in this aspect of the body, it's going to make it harder for the head and neck to drain to the thoracic duct, and it will influence how lymph is moving up through the various layers in the body. This is a little bit better image of the thoracic duct in isolation, and as you can see, the position varies depending on where you see it and anatomically what source you're looking at, but I go into more detail on that in the presentation on the mediastinum. This is the image below the diaphragm at the celiac plexus or the epigastric area, where we still have the entrance to the thoracic duct here, and you can see how it's positioned between the aorta and the vena cava. And you have the multitude of lymph nodes that are connecting to each other and to the thoracic duct. And also it's a sort of a combination cisterna chyli thoracic duct area in this spot. Not everyone has a cisterna chyli, but everyone definitely has thoracic duct. And these nodes follow the common iliac arteries down and the vena cava down into the iliac veins. And keeping in mind that the direction of lymph is up towards the thoracic duct, but you have lymph nodes connecting to each other. Some will go up, some will go down, depending on what happens. If you have a lymph node that is obstructed, then the lymph will find another way. There's always connections to other nodes. So if the direction is supposed to go up, but this node is obstructed, you might find this lymph node needs more support, so it will also send lymph down. And that's when you start to run into problems, is when you don't get optimal flow within the system itself. And the longer you get a stasis and a node gets impeded in its ability to work, then you might get a cyst. You can certainly contribute to discomfort. It could swell a little bit, but it certainly, you want to keep as much of the direction of this deeper lymphatic system moving. So you can imagine that if there's over extra tone in the aorta itself as it's coming down below the diaphragm, which is designed to enlarge, to tighten and enlarge. But if it is enlarged too much or tightened too much, that's going to affect the pressure gradients around the artery. And then that affects, in turn, the ability for the lymph to flow through the chain of nodes, especially when we're not moving ourselves, when we're laying in bed and we're reliant on the homeostasis mechanism and the pressure gradient mechanism in the body. So that's why, again, it just comes down to the pressure gradient mechanisms really are connected to that vascular component and having optimal vascular tone anywhere in the body. So just continue on, just looking at, again, here we have, when we add the liver into the image, we have the lymphatic system component, the lymph vessels of the liver, also connecting with the epigastric area. Here is that aortic arch I showed in the previous image, and those lymph nodes are connected to the lymph nodes supporting the stomach, and then you've got lymph nodes connected to the spleen, and again here the aortic arch pops out again, and so you see the lymph nodes accompanying it. So it's just an assortment of lymph nodes that are surrounding the vascular tree. Continuing on with just connecting the lymphatic system essentially from head to toe. The multitude of lymph nodes here, you can see the varying sizes. Some of them principal lymph nodes, like this one here, are a little bit bigger. This is with the urogenital area taken out, so this is a posterior aspect of that, but you can see how, again, all of the arterial supply, venous and arterial, has supporting lymph nodes, and then they're connecting as they follow the arteries and veins down into the leg through the pelvis, and keeping in mind the flow of lymph is up towards the thoracic duct, even though we are anatomically looking at the lymphatic system going from head to toe. If we're just looking at, again, that aortic vascular supply and vena cava before it branches off at the bifurcation, you can see how the colon and the small intestine lymph nodes are all interconnected and are all heading towards center, and then moving up towards that entrance of the thoracic duct to be taken up through the rest of the body. Note that there are lymph nodes supporting even the colon and the pararectal nodes here as well. So the lymph nodes are in almost every single layer of the body. Here we have the nodes supporting the rectum and anal canal, and then we have the internal iliac nodes. And so these are very small arterial branches, but you can see, like this, the intermediate nodes here supporting the superior rectal artery. And again, it's trailing downwards into the pelvis, but the lymph flow is directed up and back towards against the pressure of the tissues surrounding or in the area and the organs in the area. And so this is where we run into problems again, is if that lymph can't get out of the area due to too much increased pressure or tone in the pelvis or in and around, specifically in the sigmoid colon or distal colon, can have an impact. So you could see how a hemorrhoid might change the way that the lymphatics behave. And again, it's a chicken or egg scenario, but in order to have a hemorrhoid, you need pressure, and in order to have pressure, you need to have something occurring, irritating the organ itself and affecting the blood supply. And then the more pressure, the more limitation in blood, and the more limitation in lymph, leading to lymphostasis. So if that stays around for a long time, you get a breakdown and detoxification in the area, and then eventually you can get tissue degeneration. So even though you wouldn't necessarily connect a hemorrhoid to something more cynical occurring in the colon, but you could certainly see as a trend where it's giving you information that there is a pressure issue related in the area. And then the more chronic it becomes, the more likely that you will have poor detoxification in this area, and that would work for any area of the body. Allows us to see the deep pelvic lymph nodes extending down into the lower extremity. The same concept is obviously occurring with the arms, but I didn't provide an image for this example. The purpose of this journey through the body, even though his presentation is focused on cranial and cervical lymphatics, was again to help us appreciate the vascular tree and how it connects the head and neck to the rest of the body. So now that we've followed the deep and superficial lymphatics through the body, let's look at some forces of motion in the body. Just talking a little bit about the PRM, primary respiratory motion, or what I just call intrinsic biological motion, and we'll go back into the head and neck and why that PRM is also an expression of balanced pressure gradients and an increased likelihood of proper detoxification. At this point, we're going to talk a little bit about the cranial motion, or PRM, or primary respiratory mechanism, which is the common language used in cranial osteopathy. Sometimes I use the term intrinsic biological motion, that which is motion that is occurring under our hands that we're palpating. What's interesting about this concept is that it may not be exactly what we think in terms of the forces behind the motion. And there's new speculation examining what we might actually be, not necessarily what we're feeling under our hands, but what it is that's driving that mechanism. According to Lehm, it has become increasingly evident that the driving force of the primary respiratory mechanism expression in all fluids and connective tissues throughout the entire body may in fact be responding to a metaphysical field that moves through all living fields. In the end, what matters is that the connective tissue realm is where the adaptations occur. According to Lehm, the driving mechanism for primary respiratory mechanism is not the cerebral spinal fluid by itself, as it's been presented by Dr. Sutherland. We're getting into the territory of perhaps understanding why Andrew still believed that the artery is supreme. And as I've mentioned in the previous presentation, that the connective tissue embryologically is present before the arterial system, and the connective tissue acts as a lattice of support through the embryological development. And so I can understand why Leem is looking at the connective tissue as the area where the adaptations occur. So we're talking about the intelligence within the connective tissue, organizing in such a manner to support the blood flow. So the tissue doesn't act primarily for its own survival or adaptation. It is doing so on behalf of the arterial supply. This information is coming from the Foundations for Osteopathic Medicine, 4th edition, under the auspices of the American Osteopathic Association. Talk about recent osteopathic paradigm shifts in the realm of PRM. They believe it's the rhythmic pulsating of blood into the cranial cavity that drives the flow of cerebral spinal fluid in the brain. This is the result of vascular dynamics of the circulatory system and the cardiac cycle. Compression of the intracranial vasculature contributes to the squeezing of the ventricles, and the pumping force for the CSF circulation may be a vascularly driven mechanism. So we know that there is in fact a type of expansion-contraction movement occurring, particularly when we have our hands palpating at the cranium, and but we also feel it in other areas of the body, which brings into question whether or not CSF is the driving factor if you are in fact feeling PRM in the fibula. What is the implication of the CSF motion driving PRM? When expanding the cranial PRM concept beyond the material fluid of the CSF to include the non-material fluids located below the cranium, we must consider that the entire body expresses a PRM motion within a respective axis. All tissues contain the motion of the PRM when in a healthy state. It's difficult to make the connection to the CSF as being the primary driver of the PRM. In absence of the CSF, even if we consider it an osteopathic euphemism for a metaphysical field that can be perceived by our hands. Utilizing magnetic resonance imaging, MRI technology demonstrated brain tissue movement characterized by an inferior medial and posteriorly directed movement of the basal ganglia and inferior and anterior movement of the pons during cardiac systole. That's coming from Leem as well. What we do know is that we have the resultant movement vectors created a funnel-shaped appliance to the brain, resulting in a piston-like remodeling of the brain. The authors felt that this piston-like action in the brain during cardiac systole was the driving force responsible for compression of the ventricular system, and thus the driving force for the intraventricular flow of cerebral spinal fluid. During the cardiac cycle, there was a motion of peak brain displacement ranged from 0.1 to 0.5 millimeters. There's also motion of the brain parenchyma during systole with single displacement that returns to the baseline position during diastole. The midbrain and brainstem also descend during the displacement toward the foramen magnum, and there is a medial compression of the thalami onto the third ventricle. This image, brainstem dynamics, the cranial nerve nuclei in the brainstem. It's a posterior view with this cerebellum removed, exposing the rhomboid fossa. But in this image, we can clearly see the funnel shape of the brainstem as it would be ascending and descending through the foramen magnum. We can look at this image with the addition of the cerebellum. We can still see the funnel shape of the brainstem and the associated nervous system, central nervous system components. So it's easy to see how the functioning of the brain stem in terms of its ability to complete its piston-like motion would have an impact on the central nervous system. And I guess the question we have is, well, what's allowing really for that pistoning action? We do know that it's a vascular phenomena, as Liam has discussed. And so let's look a little bit about why it might be, why the answer to the PRM motion is in the architecture of the design of the arterial system supplying the cranium and upper cervicals. So going back to the idea of the vascular tree influencing PRM, and in this case, the vascular tree, we can just talk about the arterial supply coming off the neck into the cranium, because it does form a tree-like structure. The motion of flexion and extension in cranial bone motion and expansion and contraction, those would be the typical PRM that we feel under our hands. The source of the motion lies in the fact that all connective tissues, not just dural membranes, this includes cranial bones, they all express a PRM on behalf of incoming and outgoing blood flow. So the motion is occurring to allow for blood to enter and exit the cranium. It is plausible that the PRM is represented in every part of the body as the connective tissue expand and contract around the axis of the artery, coming back to the golden rule that the artery really is absolute. The PRM, or as I refer to, the intrinsic biological motion that we feel throughout the body, is likely, as I say, the connective tissue organizing to support blood flow. So it does bring new meaning for me to the definition of the artery being supreme or absolute. If we can accept this assertion, it could explain exactly why PRM can be felt everywhere in the body. So going back to the cranium to look a little more specifically, this idea of the axis being the artery, a major factor contributing to the adequate supply of blood flow to and from the cranium, will rely on several interrelationships between the upper cervical spine and the cranial bones. The importance of the temporal bone is critical in the context of the internal carotid artery passing within its base and structure. The secret to understanding how and why we feel a PRM, or intrinsic biological motion, in the cranium lies in the structural and physiological characteristics of connective tissues supporting the arterial system. And I'm including bone in terms of those because it's just a denser form of connective tissues. Understanding the shape and pathway of the internal, external, and posterior vertebral arteries will inform the practitioner that the PRM, or intrinsic biological motion, we strive to support is occurring as a result of the bones or connective tissues managing the rhythm of blood flow in and out of the cranium. So let's take a look at the blood supply, the internal carotid, more closely. And we've studied the temporal bone a lot, but we don't always look at the pathway of the internal carotid. So before looking at the internal carotid, I just want to remind the viewer, here we have an image of the vascular tree, and it's important not to isolate blood flow to the cranium from the rest of the body, just like we don't want to isolate the cervical spine and cranium from the rest of the vascular tree. But we want to be able to appreciate that deviations in blood supply can affect organs and tissues anywhere in the body, but it can also impact what's going on in terms of blood flow to the body. So just a reminder that we did have the mechanism, what I discussed as the selfish brain. And so if we have any limitations in cardiovascular aspects or pressure gradients in the upper portion of the mediastinum, going to add the diaphragm in here, then that can certainly have an impact on the ability for the body to deliver blood up the arterial system into the cranium. Likewise, if there's an issue with pressure here, it can affect the ability for the body to deliver blood flow down to the knee, or blood flow down to the right wrist. So thinking as a practitioner, thinking more integratively, and not getting overly fixated necessarily that if there is an issue with temporal motion, that we fixate just on that particular spot. I do think it's critical to do a thorough evaluation to ensure that the vascular tree is as open as possible. That doesn't mean you wouldn't start up here if your inhibition testing indicates it. Depends on the person. But just for considerations that the solution to opening up internal carotid artery or the freeing up the temporal bone is not necessarily an isolated issue, especially if it's chronic and you find yourself correcting the same thing over and over again. You may want to look elsewhere in the body. Here's a good image just showing the tree-like formation of the arterial supply. Now we do have the vertebral artery, and we do have the common carotid artery, and then branching off into the internal and external carotids, and at the back here the vertebral artery also branching off. I'll show some more images of this. In terms of the carotid artery, the left carotid begins at the aortic arch inside the superior mediastinum and has a direct route to the head, which is different than the right carotid artery. The right carotid begins at the brachiocephalic artery and travels underneath the sternoclavicular joint, allocating it only to the cervical spine region and not the thoracic region, as is the case with the left common carotid. This is important because it tells you that the left common carotid is likely more implicated in issues of the mediastinum than the right carotid, or as they say, the thoracic region, and more issues can implicate the left carotid. It's a shorter distance for the left carotid from the aortic arch from the heart up to the temporal, versus the right carotid is a longer distance. You may observe deviations in cranial mechanics or upper spinal C1, C2, C0, alignment with the cranial base. There could be more shears to the left, rotations to the left. You might wonder why you find a lot of those issues stemming on the left-hand side. This might be one particular explanation for that. There are other possibilities as well, which I don't present in this presentation, but they are more around the balance between the left and the right brain, and the principles of consciousness, how we're using, which part of our brain we're using fundamentally, and which are dominant, and for those types of things. A great book for that is The Master and His Emissary, and if you want to pick apart and see how exactly we are, modern culture seems to be sort of left brain dominant for the most part in the way that we organize ourselves. Interesting considerations, but we'll just stick with what we know anatomically to be true. Both common carotids pass behind the sternoclavicular joint and pass laterally to the upper portion of the thyroid cartilage at the level of C3, C4. This is where it bifurcates to form the internal and external carotid arteries before ascending the neck. The common carotid pulsation can be palpated at the level of the 6 cervical vertebrae, and it's relatively superficial at that point. The right common carotid can also be a separate branch arising from the aorta, or it can also arise from the sternoclavicular joint, as is the case with 12% of the population. It is also possible for the left common carotid to arise from the brachiocephalic artery in rare instances, so there are exceptions. The internal carotid artery, likely the most significant contributor to cranial bone motion due to its passage into the cranium via the temporal bone. The internal carotid makes 6 right angle bends as it works its way from the temporal towards the sphenoid and backwards towards the occiput, and then extending laterally to the parietals. The pattern of movement is similar to the flexion extension parameters we use to define the PRM in the cranium. Also, the cranium begins to expand at the base as it transitions from one shape to another in order to deliver the blood to the end of the carotid branches. So we have these carotid branches that are branching off the artery, but I'm more focused on specifically just the shape of that carotid. And if we follow the path of the internal carotid, we can see, even if we just follow it visually, that it pulls us along that similar pattern where we get this forward flexion, extension, and then and the opening of the cranial base, and then the opposite happens. And I believe this motion is occurring as a result of the connective tissue ensuring that the blood gets through the entire carotid and its branches to all parts of the brain. In terms of temporal bone motion, we have the flexion, external rotation of the temporals at the cranial base promotes the flow of blood towards the sphenoid. Extension, internal rotation of the temporal bone moves the blood from the sphenoid backwards to the occiput. Flexion, again, external rotation of the temporal bone allows for the blood to move externally towards the parietals, towards the ends of the arterial branch. And external rotation of the temporal bone allows for the beginning and the end of blood flow to succeed. So when we're feeling the flexion and the external rotation, it's supporting blood flow through the temporal, but it's also supporting blood flow at the end of the carotid artery in its various branches as they go laterally to the parietal aspects. So one motion is needed in order to move since there's 6 right angles in the carotid pathway, the motion of blood is sort of hidden in this, what we feel as this single motion, or this defined PRM of flexion, extension, expansion, contraction, external and internal rotation. But there is this constant flow that's being maintained, even though we are feeling it as 2 distinct motions. It really appears to be one motion that is, or one pattern that is ensuring that that the blood flow is going from beginning to end. So you can see when we don't feel that PRM motion, that we can assume that there's something going on in the blood flow, and not just CSF, and not necessarily just a lesion between cranial bones. As I mentioned, there are branches that come off the internal carotid, and I'm going to show another image that gives a little more idea of what it looks like inside the cranium. This image allows us to view the internal carotid and the posterior vertebral arteries inside the cranium. We can begin to see the 90-degree turns that the carotid completes inside the cranium. And of course, we know that the posterior vertebral also has 2 90-degree turns as it's coming up through C1 and C0. And here's your posterior vertebral here, the left one coming in, forming the basilar artery and then branching off. Here's the right vertebral coming in, joining, forming the basilar artery. And of course, the occiput bone would be over top both sides. And if we go to look at the internal carotid, here we have the passage of the internal carotid coming up through the temporal, doing a 90-degree turn, heading towards the sphenoid, then coming back on itself at the sphenoid, and then branching off laterally. And these are some of the cerebral arteries coming off the carotid. And these are other cerebral arteries coming off the carotid as well. So between these two structures, we do have that circle of Willis, which is connected by very small arteries connecting the two internal carotids, and here connecting with the posterior vertebral. So the idea of it being a circle is why it's called the circle of Willis. So we have an image of the temporal bone and the various distinctions of the internal carotid artery. And again, there are no less than 6 right angle turns that the internal carotid artery makes as it passes through each hemisphere. Just one last image with showing the internal carotid coming up in its pathway. This angiogram allows us to see what it looks like when there's an issue going on in the artery here. That appears to be some type of aneurysm. And then you have the other branches of the artery, like the middle cerebral artery coming off here. Fascinating image nonetheless. So that kind of talks about the temporal bone motion, but let's look at what is driving the motion we feel at the occipital bones. The occipital bone motion, we have the posterior vertebral arteries. They enter the cranium, joining to form together the centralized basilar artery and its branches. The basilar artery is a natural axis that is obvious when we're palpating the occipital PRM. Here we consider the flexion and extension or expansion contraction expression as two motions. The flexion expansion likely promoting artery expansion and blood flow, and the extension contraction likely contributing to venous drainage when we include the pressure gradients increasing with the flexion expansion phase. Also, I don't think it's a coincidence that the basilar artery and the Sutherland sinus are similar in its nature and in the way that the cranial motion organizes. Perhaps it's not the Sutherland sinus as much that is implicated in the mechanism driving the PRM. It does act as an anchor, but I think it's possible that the ultimate anchor, that even the Sutherland sinus is organizing in a way to ensure and protect the integrity of the basilar artery. Here we have another view, the posterior vertebral artery and the common carotid as well. And here's where we get, following the posterior vertebral artery up, we see the first 90 degree, then the second 90 degree as it goes in and organizes itself towards to form the basilar artery. And we have another image here, again showing the basilar artery as it's formed from the respective vertebral arteries coming off from the spine. This is a posterior view taking the occipital bones away. So what we have here fundamentally is we have we can see we have the internal carotid coming up here, making its formation and then doubling back on both sides. Internal carotid. We also have the posterior vertebral artery coming up this way, the right one, forming the central basilar artery here. Again, other vertebral artery. Then we have essentially the circle of Willis that is formed. And these are all various branches as well that are branching off, but I like to focus more just on the primary trunks of the arterial system, because we are looking they're delivering the most amount of blood to the cranium. This is a classic image that that we're familiar with. It's talking or indicating the circle of Willis. It looks sort of like a little man in the center of the brain there. But it's hard to appreciate the three-dimensional quality of the circle, because it really is comprised, connecting the aspects of the carotid arteries to the vertebral arteries, branches of the vertebral artery. And it's less, to me, less of it makes a circle in the sense that it connects those systems, but it's not like the blood flow is moving in a circle. I think primarily those communicating arteries, like the anterior communicating artery, posterior communicating artery, those are connecting they're small bridges that allow for communication between the main arterial branches. I don't think it's designed for the actual blood flow to be moving in a circle. I just think it's designed so that this artery knows what this artery is doing. So it's a way of just sort of, as it's called, communicating artery, just to ensure centrally that there's a balance between all those branches of the artery. At least that's my take on it. So in terms of the clinical significance of looking at the PRM being primarily driven by connective tissue organizing around blood flow and to maintain blood flow, the flexion extension PRM motion is a result of the blood in the internal carotid artery completing its journey through the 6 right angle direction changes of the internal carotid artery complex, and along with the posterior vertebral basilar artery complex. The entire cranial mechanism is changing its shape in order to promote adequate blood flow in and out of the cranium. The pressure gradient imbalances will limit the expression of blood flow in PRM motion of the cranial bones, thus impacting the lymphatic network. The result would be limited detoxification and increased inflammation. So we want to restore ideal arterial pressure gradient parameters by correcting the limiting structural tissue components, so that ideal function can proceed. So I don't think we need to develop any new techniques for restoring PRM to the cranium, but I do think it's beneficial to understand that when we are, perhaps if we are able to visualize the arterial landscape, the vascular landscape, that we may find that a more profound connection to the system, because if the system is organizing on its own around blood flow, when the PRM is not there and there's a holding pattern that's going on, that could be coming from densities or direct traumas or or just depending on the type of lesion, was it physiological or non-physiological. Whatever those parameters are, typically holding patterns are a guarding mechanism to protect blood flow. And so I think there's potential to transform the shift or the change that could occur under our hands, providing we're connecting to the right mechanism. So for me, it's more accurate to visualize the blood flow under my hands versus the motion of the cerebral spinal fluid. And I think that when the system is, as we act as a fulcrum, and when the system is reorganizing itself under our support, that's where you can have profound implications to take pressure off of nerves as well, by restoring blood flow, correcting pressure gradients, taking pressure off nerves. And in the end, we're allowing for pressure to correct, which supports that mechanism of the glymphatic system or the glymphatic network and all its parameters that I've outlined to properly function and support health. So I suppose a friendly challenge would be to follow the path of the vascular tree as you enter the cranium during the palpation of PRM. Can this motion of flexion extension be one physiological motion of blood into the internal carotid artery expressing a continuum? So this is where I was saying that flexion extension is in the scope of that flexion and extension. It allows for the blood to move all the way through the carotid to its various branches. And I suppose since the flexion being more of the active phase, where there's seems to be more of a stronger force, and the extension seems to be sort of the absence or the relaxing of the parameters, which allows for a venous drainage as well. Not sure if that's entirely accurate, but I do think that both are important. And perhaps if we're looking at lack of flexion, could indicate restriction in the initial part of the internal carotid, and lack of extension could be a limitation in the latter part of the carotid as it's progressing at the end of its pathway into the externally towards the parietals. I think we could try this in other areas of the body, considering that the axis of motion occurs around the vascular system. So whatever we're palpating in tissues and fluids as PRM, we're working towards the betterment of potential blood flow, and that's after all the artery is absolute. So that concludes this presentation, and I want to thank you very much for tagging along. The next presentation coming will be on the lympho vascular terrain of the mediastinum, where I'll be covering the heart and the lungs and associated structures, including the diaphragm. Thank you very much.